He's the chairman of the New England Health EDI Network, NEHAN, which is Massachusetts' vehicle for exchanging administrative and clinical information, analogous to some of what we do here at VITL. He's the co-chair of the National HIT Standards Committee, as well as a practicing emergency room physician. Okay, so I think I just described about 5 full-time jobs, if I check. And I think that's probably, and unfortunately, that's just the short version of what John does. So, as CIO at VID, he's responsible for all the clinical, financial, and administrative transactions for 3,000 doctors, 14,000 employees, and 2 million patients. Now, that's a bigger patient base than we have. So, and more physicians, and so I hugely admire him for doing that. As co-chair of the HIT Standards Committee, a lot of what we are doing in the world of interoperability is, depending on your perspective, due to John's wonderful contribution or his fault. And he takes both sides of that equally well. Now, I've known John for over a decade, and it really is true that all those full-time jobs is a whole lot less than what he does. And I'd also have to say, in addition to his multiple day jobs, John writes the best blog about health information technology, bar none. So if you look for Life as a Healthcare CIO at Geek Doctor, he named it blogspot.com, you will find insights into how all of this stuff fits together, written in English. In fact, I like to say that if I ever give a half-intelligible answer to an informatics question, it's only because I read about it within the previous week on John's blog and can still remember what I said. But on top of that, I'm also in awe of the fact that John receives well over 1,000 emails a day. Now, I don't like the number I get, but I don't get well over 1,000 a day. The turnaround time for responses to my emails from John, and I don't think I'm anything special, is less than 15 minutes. So you figured out how to do that with 5 full-time jobs. Nuts. So, given the breadth of his responsibilities and the kinds of things that have been going on in a cutting-edge institution like BAD, I'm hoping that he will offer us really useful insights into this intersection of the practical side of delivering healthcare in an IT environment and intersecting it with the policy environments. So my pleasure to introduce you to the man who never sleeps, also known as the Man in Black. Halamka.
Well, thank you very, very much. Wow. Okay. Well, with that introduction, this better be very good. So here, let's see. Where did my presentation disappear to? See, it's a Windows machine. I haven't used one of these in a few years. Oh, thank you very much. Well, so you guys all living the dream of meaningful use. Isn't this exciting? Anybody in the audience attested yet? Who do we have? Okay, well, progress being made, I see. So don't worry. You're going to see this huge upswing in hospital and eligible professional attestations over the course of the first quarter of FY12. So, when the press sometimes says, look at all these people working so hard, but then look at the numbers for attestation still rather small, the answer is, the culture has changed. You've probably felt this. You can be in a cafeteria and the doctors are saying, I got to record problem lists. I got to do decision support. I got to exchange information. 5 years ago, that was not the conversation that you heard. In fact, conversation was more like, we're putting in an electronic record. My productivity is going down 25%, and for the next 6 months, I'm not going to have dinner with my spouse. Oh, and by the way, at the end of the process, I'm going to deliver such high-quality, efficient care that Blue Cross is going to benefit handsomely. So, hey, we are changing the culture, so that's good. Well, today, David asked me to talk a little bit about quality, safety, efficiency, and how all this healthcare IT is going to lead us to a better state. Because recognize, we're not doing this for technology's sake. I mean, just getting software and installing laptops and printers isn't going to make healthcare better. It's really about how we're using this to engage patients and families and measure quality. And we're on a journey. I mean, David Blumenthal, of course, he was our initial national coordinator during the Obama administration, described this as an escalator, where you want the escalator to move so everyone can get on, but not so fast that people fall off. And so here's the tenuous balance. We want 2011, 2013, 2015 to march us forward to this world of accountable care nirvana, but not move us so fast that we don't get to attestation. So 2011 is really about getting the data in, moving from Regina's paper charts to electronic coded information, problems, meds, allergies, labs. 2013 is really going to be more about getting the data exchanged, coordinating care, measuring population health, and engaging patients and families a bit more. And we hope by 2015 we'll be exchanging so much data, and it'll be so beautifully structured that we can then turn data to information, knowledge, and wisdom through decision support, through having all kinds of wonderful tools that allow us to make interventions delivering the right care to the right patient at the right time. So let me reflect on a few of the things we're working on this journey. So, you guys know that meaningful use was originally established as a construct to not install technology, but to achieve these 5 policy goals. That we were going to improve healthcare quality and safety and efficiency, ensure that everyone in the country received appropriate health care, get patients and families involved. Now, example for you, and everything I share with you about my own personal health and my parents' health, I give you my consent. There is a complete HIPAA release going on here. It's okay. So on November 9th of last year, I received the following phone call. 2 in the morning, hospital in Southern California. Your mother has a very significant medical problem. It appears she has a gangrenous gallbladder, and she is, a little altered mental status, septic, not doing so well. We're going to be taking her to the OR. And your father's at her bedside, and he's so stressed, he's just had a heart attack. So your mother's going to be in ICU 5, and your father in ICU 7. Now, the only problem is we have no idea what medications they take, what allergies they have, what problems they have, what labs they had, and they're both in emergent need of care. Can you help? Oh, by the way, you're 4,000 miles away at 2 in the morning. What you hope through the policy goal of engaging patients and families is you never get that phone call. That is, we all have access to our data, whether that's through a tethered personal health record or whether it's just some means like a vendor-based system of gathering information from disparate sources and then being able to present it to those who need it. I hope that you'll see as I go through stage 2 in a minute that we're going to get in 2013 and 14 much closer to getting rid of those kinds of phone calls. In Massachusetts, not in Vermont, 15% of all the health care is redundant and unnecessary. Now, what I've been so impressed by, Vermont is a place that gets things done. It's of the size and scale, and the people have a culture that they are actually willing to make personal sacrifice to improve the healthcare system. In Massachusetts, well, you worked there for many years, I have the following conversation with the CEO of Partners Healthcare. Gary, do you know that 15% of all of our lab and radiology testing is redundant and unnecessary? So what we're going to do is we're going to build this health information exchange. It's going to share data seamlessly between Partners and Care Group and Steward and Leahy. It'll cost you $1 million a year, and it will reduce your income by 15%. It's great. It turns out that actually isn't such an easy conversation to have. But care coordination, as you'll see in stage 2 and beyond, is what we all need to do because we're going to get paid not for the quantity of healthcare we deliver, but for the quality and outcomes we deliver. That's what healthcare reform is all about. Now, if you look at the United States, we are spending 17% or so of our GDP on healthcare, about $8,000 per year. Now in Vermont, I'm sure you're much more efficient. But in Massachusetts, when I stand in the quad at Harvard Medical School, I am standing in the center of the most expensive healthcare in the most expensive state, in the most expensive country in the world. And in fact, we have poor quality and outcomes. And if you look at other countries, Japan, $2,000 per person per year, longest lifespan in the world, some of the lowest infant mortality. By any measure, countries like the UK, the Netherlands, they all have far better outcomes and far less cost. So as a country, we need to start looking at the value equation, and that's really what care coordination, population health is going to help us do. And then, of course, as you say, it's security of the records, it's integrity of the data, but also privacy. Now, I had the opportunity to have lunch in the West Wing. Obama wasn't there. He was in Martha's Vineyard or something a couple of weeks ago, and have a chat with the Chief Technology Officer of our country, Anish Chopra, who described the cybersecurity problems of the United States now as the most severe they've ever been. We are getting attacked as a country. How many times can you open the newspaper and read about this or that privacy breach or this or that security attack? It's a very nasty world out there on the internet. The networks I oversee are attacked every 7 seconds, 24 hours a day, 7 days a week. The malware we are seeing on the internet is so nasty that recently I brought in a number of companies, McAfee and Symantec and Kaspersky, and I had them try to diagnose malware infections on some of our clinical devices, and they couldn't find them. And then I brought in some guys from the NSA and the CIA, and wear little black suits and microphones in their ear, and they found all kinds of nastiness. We are at a state of technology where if you don't think you're infected, you actually just don't have the right tools. It's so bad that we have to not only defend our borders, but then bring in novel tools that will expunge those things that sneak through them. So all of the work that we're doing on security and privacy is absolutely key, and you'll see some more of that at Meaningful Use Stage 2. So I am not going to read these slides. I just want to give you a few highlights of what the policy committee is thinking as we go to Stage 2 and Stage 3, and how they reference those goals that I just went through. So if you're looking at quality, safety, and efficiency, well, we had initially a CPOE goal in Stage 1 of 30% of patients. We focused on medication orders. And so now what you're going to see as we get to Stage 2 is it's 60% for medication orders, and then we're also going to look at radiology tests and lab tests and start getting to CPOE being more common through all of our hospitals across all our order types. Now, Paul Tang, who chairs the policy committee, is very passionate about drug-drug interactions. Now, I imagine many of the folks here, well, your doctors using these systems, your technologists implementing these systems. I don't know if you've ever found this little problem. It turns out when you buy a commercial drug database, and there are many out there, First Data Bank and Micromedics and Gold Standard, they include thousands of drug-drug interaction rules. Sounds like they're very safe and protective. But as a practicing physician, I can tell you, this is one of the true rules. Now, I know you're a very healthy guy. You would never do this. But if you had 2 martinis followed by a gram of Tylenol, do you know that you have a 1 in 10 chance of getting your liver enzymes bumped? So imagine every time on my electronic record I write for Tylenol, it pops up, have you asked your patients their martini history? We would all go insane. And so what we've tried to do at BIDMC is not use the rules that come with these databases, but write 200 rules, which I'll put on my blog, I can share with all of you guys, that are what we call the FDA black box rules, the things that will kill the patient. Because honestly, if you give somebody a medication and there's a 1 in 1,000 chance that they take the medication with grapefruit juice, it will be less effective than it could be, okay, whatever. If you give somebody nitrates and Viagra, that is going to cause significant harm to the patient. So this way we avoid alert fatigue, because if you get the 1,000 pop-ups a day, you're going to just ignore them. And so Stage 2 is going to include, well, there's one thing it will include, and there's a vision for what it should include. What it will include is the ability to tune the drug-drug interactions that are presented to the doctors so that you are able to just deal with those very significant will cause harm kind of rules. And the vision is that there will be a central National Library of Medicine curated rule set which is downloadable into your electronic health record of those rules that are going to cause significant harm. And the reason I certainly think this is important, so just again taking a Massachusetts example, David Bates over at the Brigham wrote several hundred rules. I wrote several hundred rules, and they're totally different rules. Wouldn't it be great if as a country we could just agree on a core set of drug-drug interaction and safety rules? So a number of things we're also going to try to do is get e-prescribing more and more commonly used. Stage 2 bumps it from 40 to 50. It starts going to hospital discharge medications. It's not in stage 2 yet, but I don't know if you guys have started to look at the e-prescribing of controlled substances. So this is sort of an interesting issue, which is when I was a resident at Harbor UCLA, a county hospital in Los Angeles, one night I accidentally left my prescription pad and my DEA stamp in the doctor's lounge. The next day I received a call from CVS Pharmacy. Did you really prescribe 250,000 Tylenol number 3 in the last 24 hours? So you can imagine the problem if a username and password is stolen and then used in a narcotics-connected e-prescribing system. It's a problem. So what the DEA is proposing is two-factor authentication. And here's what I told the DEA. I said, you know, every doctor has a token. It's called their cell phone or smartphone or mobile device. How about this, DEA? Every time I go to write for a narcotic prescription, I sign it electronically with my username and password, and then you send me an activation code through SMS, and I just simply type in the 4-character activation code, and we're done. No special hardware, no special software, it's just a cell phone. The DEA is a somewhat paranoid organization. And they told me, you cannot use a BlackBerry. You have to use a Barackberry. Now, if you've ever seen the president's phone, it can be used to launch nuclear missiles. It weighs about 5 pounds. It's made by General Dynamics. It's very secure, not so practical. So at the moment, the DEA is suggesting that biometrics or hard tokens are what every doctor will have to use. Thumbprint scan, or the carry a little fob on your keychain with a code that changes continuously that you'll have to type in. So we'll see where all this goes, but certainly it will be a better world when all medications that we write for can be done through a single electronic workflow instead of Lipitor, fully electronic, OxyContin, pen and paper. Strange. Okay. Some other things. You know, there's the continuation of the active meds and allergy lists and vital signs. Smoking status is going to have the addition, I think this is interesting, of recording secondhand smoke. So interesting from a public health perspective. A lot of the things that you'll see in stage 1 that are the optional, the menu set, those go into core. So when you look at stage 2, you know, today you have 10 criteria that are core and 15 that are menu set, of which you choose 10. Well, these are going to, 5, excuse me, these are going to all move into core. And so you're going to have such things, and they're modified so they're reasonable, like the advanced directives requirement is you simply have to record if an advanced directive exists, yes or no, not necessarily that for every one of your patients you have one. So again, more on quality, safety, and reducing disparities that I don't know if you I guess through your HIE, you've been working on some lab result exchange. Sometimes hospitals serve as reference labs for affiliated practices, and sometimes those hospitals deliver lab results on paper or fax machine. And starting with stage 2, that will no longer be allowed. That hospitals that serve as reference labs will have to send their data through standard electronic connections, the HIE if it's available, but directly then to the EHR. And of course, it's going to be rational, so there may be exceptions for smaller hospitals for which it would create an undue burden. Now, there's going to be quite a lot of more interoperability that you'll see. And one of the interesting aspects today of our hospitals is, although our ambulatory care areas are getting more and more electronic, you guys are doing your EHRs, our hospitals, some of them anyway, I'm sure Vermont is better than normal, but are a sea of paper. And that is those SOAP notes, the progress notes, they're all paper-based. You may be using provider order entry, bedside medication verification, electronic medication administration records, but then the progress notes are written by 17 different people, the intern, the resident, the fellow, the specialist, and you create a paper chart that no one can read and has largely simply medical, legal, and not clinical value. That should change. And so you'll start seeing with Meaningful Use Stage 2 the idea that you're going to record those progress notes in the hospital electronically. Like all aspects of meaningful use, it's going to be a ramp up. So it's going to be starting with 10, 20, 30%. But it'll be great because then as we start thinking of transitions of care, the actual notes and plans that were written in the hospital can be part of those electronic summaries that flow to the next provider of care. As we think about patient and family engagement, a couple of things that you'll see. Well, Stage 2 focuses a lot on giving patients access to data. So one of the interesting challenges is in Stage 1, let me ask you guys who may have gone through the attestation process, when you were, say as a hospital, told that you must give a discharge summary or a lifetime summary in electronic form to patients who asked for one, how many patients asked for one? Okay, when I attested, the answer was 0. The number of folks going down to the basement at between 8 and 5, Monday through Friday, who say, I want one of them XML CCDs. It just hasn't happened. And so it seems as if, rather than forcing a patient to get, by request, a summary in electronic form, giving them full access to all their data, and they can control it and manipulate it as they wish, is a better idea. So you'll see notions in Stage 2 of giving patients access to personal health records, a download of their inpatient information, a download of their longitudinal records, making it very, very web-connected and self-service. One interesting thing also, as we think about communicating with patients, some may use a personal health record connected to the doctor's office. Some may use a third-party record like, say, Microsoft Health Vault. Some may actually have other ways they want to be communicated with, secure email, a portal or something. And so the idea that as physicians we would record communication preferences and therefore be able to understand how best to communicate with patients and families. I don't know, this is not for everyone. I mean, my parents are quite happy for me to be the steward of their data and their personal health record. They actually would rather not be using iPads to look at their latest medication list and labs. But I think the answer is doctors, we have to provide both fully electronic access for those who want it, downloads or static forms for those who need them, and the capacity to delegate to other family members who might be the steward or the sort of healthcare knowledge navigator for parents or children. It's the right direction. Now, as we think about care coordination, when we started Stage 1, there really are very few HIEs that are functioning in the country. And so to say you must connect to an HIE or you must send data from point A to point B, well, it was phrased as a demonstration. Now, I admit that I have done something somewhat unusual on my blog, and I'm going to actually repeat the same mistake here, which is remember that Stage 1 attestation requires that you simply demonstrate that you have the capacity to send one transaction to some non-owned other healthcare provider. So on my blog, I offer to everyone in the country to serve as the recipient. I'm a doctor as well as a CIO as well as a hospital. And so I have now gone through a couple hundred transactions of people simply email me a CCD, send me via whatever means you want, and I will be very happy to acknowledge that I have appropriately received the clinical information, achieving that demonstration transaction, which you then need to attest to. So, It's free, simple service, so it's my, what I can do for the country. But stage 2 is going to now require 10% of all of your encounters to include an electronic summary that goes to the next provider of care, and that could be a PCP, it could be a post-acute care facility. It's going to be real. And the reason this is so great is, in my example with Partners Healthcare, there hasn't been a motivation for people to need to share data, because in our country, since fee-for-service medicine pays for redundant and unnecessary care, hey, uncoordinated care is good. But in the meaningful use stage 2, you want to achieve stimulus dollars, you have to do 10% data exchange. Finally, the HIEs will have a business model where doctors and hospitals will want to use their services because they're required to achieve these stimulus funds. And then, of course, we get to accountable care organizations. They're going to need to coordinate care and build registries, and so there'll be another good business driver for that. Now, there's a couple of population health transactions. We've already done the immunization, reportable lab, syndromic surveillance demonstration transactions, and I recognize the way they were worded in stage 1 is if your public health entity is capable of receiving them, and so a lot of public health entities aren't. But as we go to stage 2, it's really now trying to operationalize that, is to get all of those transactions going to public health and move those as a core requirement. And then there's some thought about even trying to automate cancer registries, but that's probably likely going to be stage 3. And then from the security standpoint, do an in-depth assessment and do risk mitigation, as I talked about, because the internet is such an evil place. So stage 2, lots more healthcare information exchange, much more patient engagement. And stage 3, we start hearings on the 14th. So we're going to start doing the process of the next couple of years. From a timing perspective, and I know this can be slightly confusing, stage 2 is going to be deferred 1 year. And so what this means is you'll get all of your money. If you've attested in FY11, you'll get all your money for FY12 purely based on the stage 1 criteria. And here's the reason it was moved. So high tech originally had the somewhat aggressive schedule of saying 11, 13, and 15. The way unfortunately, we are where we're at, the standards for stage 2 will be finished at the end of September, which means we'll get a notice of proposed rulemaking in December, which means you'll get probably a final meaningful use stage 2 rule in April or May. And then, as initially worded, high tech would require vendors to write software, fully install it, and clinicians to begin using it by October 1st. Wait, between April and October? It's impossible. And so monies will flow as they were originally intended to flow, no interruption. All that will happen is that the reporting period for stage 2, instead of beginning October 1st of 2012, will begin October 1st of 2013. So for those who attest in 2011, you'll basically get a free ride in 2012. And so it's a reasonable policy compromise. The advisory board wrote an article telling everybody, don't attest in 2011, because if you do, you'll run into this timing gotcha in 2012, having to move too fast. And the answer is, the policy is being changed. Don't worry about it. Attest now. It'll be fine. Well, I promised David I wouldn't get into bits and bytes, because the standards, well, how do I put it? Anybody in here part of a standards development organization or work on standards making? Okay, so good. I don't have too many people I'll insult. It turns out that there are people who are forest people, and there are people who are tree people. Well, people who make standards are bark people. And alas, we could spend all day in Washington debating whether an ampersand or a semicolon is more appropriate. So what we have had to do over the course of April through September is create all the standards for stage 2. And this was called Summer Camp for Standards. No swimming, Wasn't very exciting, but we met every other day by phone or in person from April to today. And here's what we had to figure out. When we send data from point A to point B, alas, in the United States, we don't have a national healthcare identifier. How do you wrap that data in an envelope so we know where it's going and what patient it refers to, and if there's special privacy protections about the contents of that electronic transaction? So I'm sure you don't have these quizzical laws in Vermont, but it turns out that in Massachusetts, to disclose HIV information requires not only consent to disclose, but consent to view. So you could go to the hospital and say, I am signing a consent, disclose all of my information to anyone who wants it, but then each time, each episode by which a clinician queries that information, should it contain HIV data, a consent to view has to be obtained. So hence the idea that if we are going to start sending information that contains HIV, mental health, substance abuse, sexually transmitted disease, domestic violence, there are things that may have certain state-level regulation about special consent modalities that we have to be able to flag the envelope, saying, I'm not going to tell you what's in this envelope. I just want to let you know that what is in it requires a special consent. And therefore, before you open the envelope, you get a consent from the patient to do so. So we finished all the standards for identifying the patient, ensuring the integrity of the sender is known, that it came from Beth Israel Deaconess, it wasn't opened, and security flags. Another challenge is, I want to send a transaction from Fletcher Allen to Dartmouth Hitchcock. Well, how do I know how to do that? I mean, unless there's buddies and they've exchanged IP addresses or special email addresses, there is no provider directory that enables me to go from organization to organization and know how to route things electronically. So we've worked on standards for that. And there's still a little controversy on that one, so there may be a couple of options in the regulations. Patient matching is a very tough thing to do. So let me give you a real example. As part of integration between Beth Israel Deaconess and Atrius, a multi-specialty provider organization, I had to figure out how to get Epic to talk to Meditech, to talk to some home-built systems, and to exchange information as doctors needed it by clicking a button. And to do it, we decided we would use name, gender, date of birth, zip code, probabilistic match on demographics. Well, I don't know if anyone is familiar with the demographics of Boston, but it turns out that, let's take South Boston as an example. Patient presented to Beth Israel Deaconess whose name was Maureen Kelly. Born September 1st, 1951, zip code South Boston. And it just turns out that there are about 5 Moira or Maureen Kellys born on that same date, in that same zip code, and so patient matching fails when you have less than completely random name association with a zip code, alas. And so what we've tried to do as a country is publish guidelines on how you should do patient matching, understanding the sensitivity and specificity implications of using different demographic indicators. The notion we had, and you can decide, of course, this is not going to be in regulation, is that specificity is more important than sensitivity. And that is, let's imagine sometimes Cochran is spelled with an E at the end, sometimes you're Dave, sometimes you're David. It is far worse for me to combine the wrong data from wrong Davids than it is to occasionally miss a piece of your record because somebody misspelled your name. And so this is the notion that is laid out in these various standards. Vocabularies are really important for interoperability. Last evening we were talking about the challenge of doing analytics on the medical data we collect. The problem is every one of us as clinicians, well, I call it hypertension. You call it elevated blood pressure. I have a definition of a fever that's 101.5, greater than 24 hours. You define a fever if the patient feels hot and sweaty. I mean, right? Everyone, alas, refers to our medical terms in a different way, and problems and meds and allergies are all recorded in a disparate fashion. So what, at the end of the month, we will have for the country is one uniform set of vocabulary terms for EHRs and hospital information systems to use for every domain of medicine. And it was been really skinnied down and simplified so that the vendors will have a pretty straightforward time implementing this. And admittedly, there will be opportunities for innovation, because I know that not all of you probably woke up this morning thinking SNOMED codes or LOINC terminology. So translating what clinicians write into codified, interoperable vocabularies will be an interesting opportunity for vendors. Discharged medications from hospitals today typically, well, some don't go to retail pharmacies. What you have is EHRs doing e-prescriptions to retail pharmacies, but hospitals may have an internal pharmacy, may write on paper, so we had to create all the standards to allow hospital discharge to flow to e-prescribing networks. Stage 1 had an interesting mistake. And see, many of you, if you don't live in the weeds of standards making, this is actually what happened. The Office of the National Coordinator wrote a letter to the CDC, said, please give us your best final implementation guide for syndromic surveillance, because we're writing national regulations and anything we put in the Federal Register will become law. And so an implementation guide was sent, and unfortunately it was the completely wrong implementation guide. It had absolutely nothing to do with syndromic surveillance. It was infectious disease reporting, and the wrong implementation guide was published in the Federal Register. And then about 2 weeks later, the Office of the National Coordinator wrote a retraction saying, never mind. And so stage 1 actually includes no recommendations for syndromic surveillance. It just says, use whatever standard you feel like. Stage 2 needed a set of standards. What we did is we re-looked at all the public health transactions, immunizations, reportable labs, syndromic surveillance, and came up with one standard, one implementation guide, one version. So it now, for vendors, makes this really easy. And for health information exchanges, too. One of the challenges all of us have in connecting labs is that once you've seen one version of HL7, you've seen one version of HL7. And alas, I don't know if you have a cost you've estimated, but it can cost $10,000 to simply create a robust interface between a laboratory and a hospital. Come on, guys, this is a standard, right? It should be plug and play, not plug and pray. Or as you said, plug and struggle. And so we have come up with one lab standard for the country that includes compendia for ordering. It's all vocabulary controlled with no variation or optionality. Transitions of care are increasingly important as we send patients from hospital to PCP, PCP to specialist, or hospital to LTAC. And so you'd like the ability to send problems and meds and allergies and labs and dietary restrictions and care plans and all of those things that constitute a nice care summary in a fully electronic manner. Stage 1 required the continuity of care document, which was okay. It's sort of a fixed set of data elements. So what we've come up with is now the next evolution that is a templated system using the Clinical Document Architecture, CDA. Sorry for the acronym here. But basically think about it this way, that if a hospital decides it wants to send a problem list, that's okay. There's a template for that. A medication list, a template for that. Allergies, templates for that. X-rays, template for that. So it's a suite of predefined templates that any vendor then can simply assemble into a transition of care document that can be used for any purpose. So it doesn't have one fixed document for everybody. It's templates that you can assemble as you wish. In a sense, interchangeable parts. Getting data from point A to point B turns out to be another tricky problem. So if we've solved the issue of how to do vocabularies or how to represent transfers of care, still it's murky how you should transmit information. So everybody is building HIEs, but alas, we're going to end up with 56 different HIEs with no capacity for any of them to connect with each other. So hopefully the country can standardize on a couple of approaches, just a few approaches, to get data from point A to point B. And we are coming up with a set of recommendations that are building blocks, that are components of using what's called the Direct project, what's called the Exchange or Connect project, to be able to send data in standardized fashions, whether that's between two healthcare entities or a healthcare entity and the government. So those will also come out at the end of the month. So quite a lot of interesting stuff this summer, and the hope is, as you say, I get credit or blame, I'm not sure which, is that it suddenly constrains all the optionality that we have. I mean, I think about the journey in standards 10 years ago. There were so many choices and so many versions that we ended up with a lack of interoperability. I mean, the great thing about standards is there are so many of them, right? So if we can, in 2011 to 12, get to fairly few standards, a dozen or so, it will make lives much easier for vendors and for users. So I've talked about some of the federal stuff, but let me get into the trenches, because as you say, I'm now responsible, and I didn't sign up for this when I took this job, with actually delivering interoperable health records to not only 5 hospitals, but all these doctors in the community that we don't even own. And I'm sure you guys have all gone through a journey something like this, but here's how it started. Stark had these wonderful safe harbors that allowed us as a hospital to provide subsidies to electronic health records for doctors in the community. So I went to all of these non-owned, loosely affiliated docs around Boston and said, have I got a deal for you? I am building a cloud-based, hosted software as a service, electronic health record, and I will pay 85% of the implementation costs. To which the doctor said, yeah, but that means we have to pay 15. Where's the deal in that? Yeah. So then, brilliant idea. It turns out physician organizations over the course of the last couple of years had some retained surpluses and withholds. They had some money set aside. So although the hospital could only pay 85, by partnering with physician organizations, I was able to come up with a package that made electronic health records free. To which the doctor said, okay, same thing I started with. I won't have dinner with my spouse for 6 months. My office manager's going to quit. It's going to take me much longer to see patients. This sounds like a bad deal. Free is not cheap enough. Then we said, okay, here's the deal. We'll have a 20-person SWAT team that descends on your office, redesigns all your workflows, installs the medical records and the hardware, and does everything at no cost to you. You will simply, by law, have to pay ongoing maintenance fees because we can't cover that. And then Meaningful Use will give you $44,000, and you get to keep all of it. Okay, I do nothing and get $44,000. That's cheap enough. And so then we signed up 1,758 docs on that plan and then implemented them through a cloud-based data center that I have now had operated by an outsourced firm. So if things go bad in the middle of the night, I don't get the call. But it does provide us with an interesting challenge now as we do accountable care organizations, and I'll reflect on a few things that we're doing, of commingling data from all of the various EHRs used in our community into registries and repositories for quality analysis and being able to deliver these reports back to docs about their performance. So let me just reflect on a few themes here. So there are 3 ways that you can do interoperability. I'll call them pull, push, and view. So pull. The idea is, turns out, David shows up in the emergency department at Beth Israel Deaconess. You're unconscious, but I know your name, gender, date of birth because you got your wallet, And I know that since you live in the South Shore, that you're likely to have records, at Atrius. Let's just pick up a place. Yeah, okay. So I then issue a query to Atrius. I've got this guy, name, gender, date of birth. Do you have records? And by the way, I'm a healthcare institution. We have an agreement of data sharing. All appropriate consents and legal agreements are signed. And the answer is, oh yes, we have such a person. Okay, click, send me that data. Send me a summary. And that's the idea of I'm pulling data from multiple disparate locations using some standards for querying. It turns out this is actually very hard. And I mean, the patient matching is hard, the policy frameworks are hard, the standards are just getting finalized. But as part of all these relationships that we've had recently forming for our emerging ACO, I've had to create this matrix. Every time the CEO goes out and signs another deal, it's, okay, Meditech this, Epic that, eClinical works here, and trying to figure out how all this data sharing will work to pull information. Now, ideally, as a state, 2015, it's going to take a while. We'll get to a point where we have a central record locator service, the idea that every time you register for care, your name, gender, date of birth, and the fact that you have been at a care site is sent to a state-level repository, so then a simple, standard way, querying where you've been, getting enough information to then to query the data source and assemble the record will not be a bunch of one-off custom implementations, but a statewide uniform implementation. It'll just take a while. In the meantime, what we find is a much easier way to send data from here to there is to push it. And push, well, there's a lot of technical ways you could do this. In fact, the standard that is now being favored at the national level is using email. It's a secure email mechanism called Direct, that when I have a patient discharged from my clinic or hospital, that I wrap up a summary and I send it electronically to the next provider of care, to the patient-centered medical home, to the personal health record. I just send it where it needs to go. So there isn't this challenge of having to do patient matching or figure out where the records are. It's pushing them around the community. And so we've been doing this since 1997 with this New England Healthcare Exchange Network, NEHIN. And we do about 100 million transactions a year being pushed from place to place. And it's worked pretty well. Challenge we have today is pretty straightforward to send them, a little harder to receive them. And that is not the many EHR vendors have the capacity of taking a data source from an external site and then incorporating that into their record electronically. So, again, just true disclosure, this is how our work with Atrius has actually transpired. I generate a fully electronic, vocabulary-controlled, structured XML document that goes securely over multiple protocols from NEHIN to the Atrius Health Information Management Department, where they then cut and paste it into Epic. And Epic will be doing a more automated receipt in the future, but that's the last sort of the nature of where we are in healthcare information exchange at the moment. 2013, probably going to get better. So if I think 2015 for more pull, 2013 for more push, sounds reasonable. Now here's a problem that we all have. Our medical records are a lot of text. And although it's true, we're doing problem lists and medication lists, there's a lot of subtlety that we record in our notes. So one of the challenges that I'm facing is how do you discover useful information in notes? How do you build a Google to search the notes that are inside a medical record in an institution? So examples of the sort of challenges that we're facing. Imagine that I want to do a research study on people who I think use alcohol a little too much and might be, say, enrollable in an alcohol cessation or counseling program. Well, I actually did this study, and I went to search all the notes in our electronic health record for 3 million patients for the term uses alcohol. And I found a guy. He uses alcohol every morning. Sounds like a really awful case. To clean his skin before injecting his insulin. So wait a minute, there's a guy with good bacterial hygiene that I'm trying to enroll in a 12-step program. It's a problem, right? So alas, the notion of using discovery mechanisms that are beyond just searching for keywords is something that we're beginning work on. And here's just some examples for you. Just for fun, go to a browser, go to Google and type, what is the height of the Empire State Building? It'll actually come back with an answer for you. It won't give you some bunch of esoteric pages. I don't know if anyone saw that Jeopardy episode with Ken Jennings and the IBM computer. Well, it was pretty clear that that IBM computer, Watson, was doing its very best job to pattern match using English language. I mean, it did some silly things like declare that Toronto was a US city, but it generally showed the technology is emerging. And so here are some of the things that are just very hard to capture in a structured electronic record. Patient's afraid of needles. Patient fears weight gain with metformin or is concerned about becoming addicted to pain meds. How do you put that in SNOMED? How do you put it in a problem list? So if we can start to build these tools that enable clinicians to search the record and find novel concepts without having to read thousands of pages, that's important. So I was in Scotland a couple of months ago. Anyone from Scotland? Okay. Well, so yeah, I'm just trying to be careful here. And they have a pilot program to actually build a very large repository of free text notes and search them. And they hired a company called InterSystems, which has a company called I Know that is capable of searching for concepts. And the idea that I'm going to look at subject, predicate, object relations, causality, what caused what. Well, it turns out the two most common terms they found in the Scottish notes were wife and alcohol. And what wasn't clear was what the relationship of those two concepts were. That is, I drink too much and the wife is not so happy, or the wife is creating anxiety and therefore I drink too much. And so, in fact, it was through natural language processing, through the idea of using sort of advanced search of records, that it was quite clear that it was the males who drank too much and therefore the wives were overly or appropriately concerned. But examples too, is we write things sometimes in notes that are hard to parse or interpret or hard to represent in a structured way, especially things like medications. And so what we're trying to do, just experiment with building advanced capacity to search our free text that will give doctors some insight and identify in a visual way the concepts that are key and important in a patient's care that recur a lot. Well, another way we're starting to think about our data is once you have structured data, you'll want to analyze it. And what tools do we use? So let me give you an example of how, once we have the data, we can empower physicians. Suppose there's a protocol or guideline for congestive heart failure. Turns out it's Lasix and ACE inhibitors and nitrates and sodium restriction. Well, a patient keeps bouncing back to the hospital for congestive heart failure admissions. Wouldn't it be interesting if you could have a dashboard that was visual that would show every patient in your panel that had congestive heart failure, showed what treatments they were on, how they varied from protocol, and then developed a visual score of maybe green, yellow, red, showing you who needs an intervention and where you're likely to make a difference. I mean, these are the kinds of things that now add layers of wisdom onto the data that we've been collecting. So let me just show you a couple of examples of what we've tried to work on at Harvard. So we have 17 hospitals associated with Harvard that mostly don't like each other very much. And so they don't typically want to pool data into a registry. They don't really trust the data leaving their firewall, but yet we have important questions that we want to ask. Maybe we hear that Vioxx causes MIs. So maybe we across 17 hospitals want to be able to say, how many patients do you have taking Vioxx? How many of those patients have presented with symptoms of myocardial infarction or chest pain? We don't have to combine the data from the Mass General and the Brigham and Beth Israel Deaconess and Dana-Farber and Joslin and Children's and Mount Auburn into a giant repository to ask questions like that. You could send out a distributed query, sending the question to the data, and then simply get an answer back. Oh yeah, you're right. 50% of all of our patients who are on Vioxx have had complaints of chest pain. So we built the system a couple of years ago called Shrine that allows a web-based Boolean query where you can drag and drop 22,000 medical concepts into queries, patient this age, that gender, this symptom, or not that symptom, and then send it out to all of these various hospitals. And then we've built some plugins. I mean, it's like the App Store that you can just drop into this web-based framework, and then this is all open source. So there's a lot of developers that are working on it called I2B2. So you could see things like a visual demonstration of demographic distribution based on the query that you have asked, or comparing two cohorts of patients one to another. Or how does the course of a patient's care vary over time based on the questions that you've asked? Here's a silly one we discovered here. So David, you're a doctor. Do you know that the average human white count is 8 in the morning and is about 11 at 2 a.m.? Well, do our white counts as humans vary over the course of a 24-hour period? Of course they don't. How many people order a white count at 2 in the morning? It's not very common. And so what we discovered by actually doing this study is that if you had a white count ordered at 2 in the morning, you would get blood cultures at 4 in the morning and antibiotics at 6 in the morning. So if you want to go right for a white count at 2 in the morning, don't bother. Just order the antibiotics. You'll be done. It's not precisely scientific. It's not precisely evidence-based. But it's the kind of thing that you can see as you look at thousands of patients across multiple institutions as to what results you see, varying time of day, and what actions follow them. So the idea of doing this, which you'll see a government effort launched in the course of the next month or so called Query Health. Rich Elmore, who used to be at IDX, will be actually leading this effort. And it's going to look at how to send questions to data and build the national standards so that we don't, all of us, have to commingle our data into a giant Oracle database in the basement of the White House. Far better to leave it highly distributed so that privacy is protected. One thing you may ask is, how do we prevent malfeasance? So, my next door neighbor is a little crazy, and he's got one blue eye and one green eye, and I'm convinced the guy is on psychiatric meds. So you see what I'm going to do is I'm going to issue a query to all the hospitals in Boston. So, is there a blue-eyed, green-eyed psych patient? It turns out we don't allow queries that get to the level of that specificity if there's less than 10 patients that are returned to a query result. We add a random small number, so you will never be able to identify the characteristics of a single individual. And so this is just an example of how it works today, is multiple institutions being queried with complex questions in real time. You get an answer back in about 20 seconds, and there's no IRB approval required because you're not getting person-identified information, you're getting counts, you're getting numbers, it's population-based. Now, as we go forward, there's going to be a whole lot of interesting new data sources we're going to have to start thinking about. So, just some examples. Imagine that accountable care organizations are going to require us to deliver such high quality, cost-effective care. We are going to put bathroom scales in the homes of every congestive heart failure patient because we want daily weights to be transmitted electronically to personal health records and electronic health records. Now, I have a Why Things scale at home. Anyone have one of these? You know, you step on the scale, and within a few milliseconds, it sends your weight and your body mass index to your personal health record, your doctor's office, and in Twitter, if you'd like, but that would be weird. So purely did this as a demonstration, and it's a very interesting, novel source of data. And actually what you can see about me is that my weight varies, plus or minus about 3 pounds a year, and there's a seasonal variation. When it gets fairly cold outside, I tend to, bulk up a little bit, and then when summer comes, I go down. But for a congestive heart failure patient, this could be a harbinger of decompensation. They gained 2 pounds overnight, time to bump up the Lasix dose, home visit, keep them out of the hospital. We'll have a variety of data sources like SureScripts RX Hub and other data aggregators. So you may know that 150 million patients are already aggregated in our national e-prescribing networks. And that's an interesting data source to query, especially in emergency departments. Or Massachusetts, and I imagine Vermont might do something like this too, we have the prescription monitoring program, where every narcotic prescription is in a singular database, and an emergency department can look by patient to see what narcotics have been dispensed to that patient. Last evening we were talking about some cultural differences between some of the states in New England. And so, for example, Massachusetts, Vermont, we think of narcotics addiction as a public health problem that we want to solve by the creation of novel IT infrastructure, and in New Hampshire it's illegal to do so. So, no data aggregation of that nature is permitted. So, we'll have fun as we deal with these new data sources with different policy and cultural issues. Social Security Administration is beginning to do summary exchange for disability adjudication. So that's a novel HIT efficiency effort. And the CDC is doing lots of surveillance with BioSense. You'll start seeing some medical societies that are aggregating some data that help with quality reporting. And turns out that the quality data center that I use for the aggregation of all of our information is actually hosted in the Mass Medical Society data center. And the way this thing works is that as eClinicalWorks or Meditech or our home built systems close out an encounter, they send a comprehensive summary in the continuity of care document format to this quality data center, where then we aggregate the information for population health analysis, our meaningful use measures, all of our PQRI measures. They're all generated from a central registry. We're starting to see more and more public health departments connect up gateways to receive these types of transactions that are required in meaningful use. I mentioned the home care kinds of scales, but I also think you may have patients through personal health records that are providing more subjective data. So example, my father has multiple sclerosis and has for 15 years, and anyone who's treated MS, it's a very subjective disease. How do you feel today? What is your pain? What is your flexibility? What is your mood? And so the personal health record of Beth Israel Deaconess is actually a required part of all of our MS clinic patients, because that's the only way they can titer drugs and treat those patients effectively. Now, admittedly, Google did recently pull the plug on its Google Health product. Anybody have a Google Health account? Okay, so a couple, yeah. So Google, what a remarkable user interface, very, very nice piece of software, but Larry and Sergey were kind of worried about the project for probably 2 reasons. The first is privacy breaches are very expensive these days, and having Google Health breached could be a significant liability. But probably more concerning is that HITECH Act requires new responsibilities for any personal health record vendor, including business associate agreements and auditability. And Google will therefore have to disclose all of its internal operations and all of its business secrets, and you could imagine that would not be something Larry and Sergey wanted to do. But in the meantime, we'll have Microsoft Health Vault and other emerging products. Well, let me just close with genomics, because as you guys read the literature, you'll hear the cloud, you'll hear buzzwords of, this and that. Genomics and the impact of personalized medicine as we start to gather data is something you'll hear more and more about. So 2 years ago, George Church, a researcher at Harvard, decided that 10 individuals would be the first 10 people sequenced so that we would have 30 billion base pairs on each of these 10 individuals, complete photographs, all of their phenotypic measurements, and their entire medical records, person-identified data sets released to the public and the research community, and also stem cells, or microbiome, lymphocytes, oral mucosa. So I was the second volunteer, and so this is the PGP group, the Personal Genome Project group, and so I'm over in the left-hand corner there. And so I disclosed 2 years ago that all of my genome was available now in the public domain as a data set. And it's had some interesting moral, legal, privacy implications. So my daughter, who's 18, had to consent at the time that I would basically be exposing the family genome to the world, and all of her future life mates would have the capacity to look at what genes she potentially carried, or at least half of them. And she was okay with that, and basically her reaction is, if any boyfriend was deeply concerned about my genes, I wouldn't want to associate with them anyway. So there you go. So what did my genome show? So handing 30 billion base pairs to a clinician is not very useful, but handing them a list of biomarkers and probabilities, that's pretty useful. So in my case, I carry Charcot-Marie-Tooth type 4, a hereditary neuromuscular disease not expressed in me or my daughter. I carry severe combined immunodeficiency, never expressed before in my family, but it's interesting that I'm a carrier. I am more susceptible to tuberculosis than the average person. Turns out I ran the multi-drug resistant TB unit for Los Angeles County for a year. So I think I probably passed this particular risk. I have twice the average risk of prostate cancer. And so if a PSA went from 0.4 to 4, that'd be something that I would be very concerned about. I have a negative KEL antigen, which means if I get 2 blood transfusions, I might get a reaction the second time. And the most interesting part of my genome is I have 6 genes that predispose me to glaucoma. So I had all of the sequencing done. Being a physician, I have not sought primary care in a decade. I'm a very, very bad patient. But I saw 6 genes for glaucoma, better go to an ophthalmologist who measured my intraocular pressures as 26 in each eye. Average is about 13. And so, in fact, I've had glaucoma for years and just didn't know it because it's a silent cause of blindness. I've had no visual changes, and so I was put on appropriate medication, and now for the rest of my life, I will have completely normal vision. So what the genome did was it gave me a set of probabilities that guided my behavior, and I made choices that resulted in higher quality, lower cost medical care, because it's far easier to give me Xalatan as a drop in each eye once a day than to treat my blindness for 20 years. Obviously, this is not going to work for everyone. There's a challenge with explaining the genome to your patients because it's probabilistic, not deterministic. That is, what if you had a 20% increased chance of colon cancer? Well, gee, for a young, healthy person, the incidence is 1%, so that means 1 to 1.2%. They're going to leave the office hearing, I have a 20% chance of cancer. They're not going to be able to do the calculation of how probability affects their life. So that's a problem. I said that it probably reduced my care costs. Well, what if people who are so anxious already now see a set of numeric probabilities and decide to get total body MRIs? We could actually see an increase in cost by the worried well. And actually, anxiety could be a bad outcome of getting your genome sequenced. But what you hope is that we'll be able to tailor therapies, giving the right drugs to the right patients that are going to get most effectiveness with fewer side effects because we've been able to stratify patients and deliver personalized medicine with the genome. The cost of sequencing the first human was $350 million. The cost of sequencing the second human was $2 million. The cost of sequencing George and I were about $100,000. The cost to sequence a human today is $500. So, gee, if you could get a set of full genome sequencing for $500 that would tell you you have a high likelihood of developing cardiovascular disease, therefore look at dietary modification while you're young and healthy, maybe will actually reduce costs and improve quality. So I think a next, not stage 2, not stage 3, but beyond, part of our medical record will be genetic markers and using the genome for decision support to deliver personalized medicine to all of our patients. So with that, we have our session for Q&A, and I am happy to take any questions about what I talked about, as well as any esoteric detail, because you would not believe the questions that I am actually asked about meaningful use, like, I have a part-time acupuncturist who comes in on Saturdays and uses an EHR. Do they get a stimulus package? So I blog every day on all these issues, as you said, and happy to help you in any way I can. So,